everybody on Instagram. Waiting to go live here on Facebook. And I'm just confirming that we're good to go. Awesome. So welcome everybody to the PT on Ice Daily Show. It is Fitness Athlete Friday here on July 31st. And I'm excited to spend a little while talking to everybody this morning about the set of conditions commonly referred to or diagnosed as shin splints, which, as we'll talk about today, is something that I think we have to do a better job at understanding how to go about diagnosing the subconditions of shin splints, because it's a umbrella term that I don't think gives us enough information about what's actually going on to make informed decisions and help somebody out that is dealing with, quote, shin splints. So before we dive into that, a couple courses that we have coming up inside of ICE to take a look at. Next weekend, August 8th and 9th, we have the ICE sampler. So unfortunately this year, due to COVID restrictions, we are not doing the ICE sampler live like we like to do every year, but we are really excited about the online format and the lectures that we have lined up for you. So take a look at that. There's still room to jump in there with us for the virtual live sampler this year. Then the following weekend, August 15th, Jeff is going to be in Chicago, Illinois at Rally Physical Therapy discussing lumbar spine manual therapy management there. Then August 29th, cervical spine will be going to Manhattan, Kansas. And then August 31st, Advanced Concepts in the Clinical Management of the Fitness Athlete. So that's a course that I teach alongside Mitch Babcock for those really wanting to specialize in managing fitness athletes, the CrossFit community, powerlifters, Olympic lifters. That's the course for you. So check all of those out at ptonice.com. Now let's jump into today's topic around shin splints and understanding a little bit more about that set of conditions. So first, it's important for us to define what shin splints is. If you go into the research, you're going to find multiple different definitions of shin splints, and nobody really, to my knowledge, agreed on exactly what they define shin splints is, but we're just going to define that today as pain somewhere in the lower extremity. So below the knee, above the ankle, and it's really important for us to understand as medical professionals that the term shin splints is an umbrella term that can be used to describe one of many different conditions. So it is not a diagnosis. It's just basically telling us that somebody has pain in their lower leg. And underneath that umbrella is where we're going to actually get to a few different diagnoses. I really like the diagnoses put forth in this research article, exercise-related leg pain, a review of the literature. That's kind of the definitions that I'm going to use today. I really like how they kind of frame things out in that article. And they talk about 6 different conditions that fall underneath the umbrella of shin splints or exercise-related leg pain as they refer to it. And those 6 conditions are medial tibial stress syndrome, chronic exertional compartment syndrome, stress fractures, tendinopathy, nerve entrapment, and vascular pathology. And for today, we're going to focus on those first 4 because they're going to be the ones that you most commonly see. And most commonly when somebody comes into the clinic discussing or with a diagnosis, whether that's self or from another medical practitioner of having shin splints, they're typically going to have one of those 4. So I want to just spend some time breaking out those 4 so that hopefully we refine a little bit of your clinical reasoning when somebody comes in with pain in the lower leg so that you're better able to pinpoint what might be going on there to better establish a plan of care. So we're going to start by discussing medial tibial stress syndrome, which, if you look at the research, is going to be the one condition that some research studies will kind of interchange back and forth in their definition there. They will call medial tibial stress syndrome shin splints. But the hallmark sign of this is pain along the lower medial 1/3 of the tibia that often warms up with activity, and that pain typically is going to resolve with rest. And you'll find a number of different definitions underneath medial tibial stress syndrome that certain people have put out. But really most commonly, you're going to see it affecting the muscles of the soleus, the flexor digitorum longus, and the posterior tibialis. And I'll say clinically, I have found medial tibial stress syndrome in multiple athletes that came to see me after receiving the diagnosis of, I think you have a stress fracture even though your x-ray is negative. They've then come to see me after somebody else diagnosed them with a possible stress fracture. And when we spend a little bit more time breaking their symptoms out and testing a few things, it became clear that it was more of the muscle injury than it was bone injury. But we'll talk about stress fractures more here in a few minutes, because obviously if somebody is dealing with a stress fracture, that is something that we do not want to take lightly, and we want to be really aggressive on that management. But when it comes to medial tibial stress syndrome, some other important things that you're going to find with them is you're not going to see neuro symptoms. So you're not going to see numbness or tingling like we will with some of the other conditions that we'll talk about here in a minute. And what you're really going to find is that strength testing reproduces their pain. So when you do some form of manual muscle testing. So for example, a lot of times when I see this in individuals that maybe the soleus is a little bit more irritated than others, if I have them do a standing calf raise, so I have them stand a couple feet away from a wall, arms outstretched with their hands on the wall, which basically forces them to go straight up and down with their calf raise and standardize it as best as I can. When they do that with their knee straight, they don't have pain. But when I have them bend their knee and go into a little single leg squat and then do the act of the calf raise, that kind of reproduces their symptoms. When we really kind of try to bias that calf raise towards their soleus muscle, that turns their symptoms on. And we'll also kind of see the same thing from a flexibility standpoint. So they lay prone on a table. I stretch their ankle into dorsiflexion with the knee extended to kind of bias the gastroc a little bit. Pain symptoms don't come on. When we bend the knee and then load that up, I usually put my body weight through them to see what it looks like with load on it. That may turn their symptoms on, but really in that point, when I then say now plantar flex your foot and press into me while we have that knee bent, that's when their symptoms really get turned on for me clinically. And combining that with things like doing a bump test where I smack the bottom of their calcaneus, or I have them do a heel drop where they do a calf raise and they drop onto their heels really rapidly. Those sort of things don't reproduce their pain. But again, those flexibility tests, manual muscle testing stuff does, and palpation into the muscle bellies or right where the muscle bellies start to insert onto the bone reproduces their pain. And that combination of things helps me really clinically start to think that this is way more biased towards these soft tissues rather than the bone. So what you'll see in the research when they talk about this is often they're saying that it's the muscle's attachment onto the bone that's getting really, really irritated. But spending the time to break that out in somebody that you suspect a stress fracture with can be really valuable, because if it's somebody dealing with a stress fracture, obviously we're going to really quickly remove them from stressful activities. But if it's somebody dealing with medial tibial stress syndrome, we're more going to address their training volume and loading up those muscles and try to build the baseline fitness of those muscles up so they can tolerate the activities that individual wants to do. But certainly if you suspect a stress fracture and you have not been completely confirmed that it isn't a stress fracture, be more cautious rather than more aggressive here. And we'll talk about stress fractures here in a minute. So the second condition that we'll discuss is chronic exertional compartment syndrome, which I'm sure a lot of you are familiar with. An acute macro trauma compartment syndrome. So say somebody goes and has a car accident that creates some sort of trauma to the shin that now is developing compartment syndrome. That is an emergency, and that is not what we're talking about here. When we're talking chronic exertional compartment syndrome, we're discussing that as an individual exercises, typically runs, blood is filling the anterior compartment of their shin, and basically that leads to increased pressure inside of that compartment, which can progress to the point where they get pain, weakness, numbness, and that pain's often going to be described by these individuals as a cramping or a burning feeling. Very commonly this happens bilaterally, and very commonly this happens at a very specific set distance. So a runner will come in and they'll say, yeah, when I go out and I get to about the 3 mile mark, that's where my pain turns on. When I get past the 3 mile mark, when I get to about 4 miles, I can't stand it anymore. I can't run anymore. I have to stop, and there's nothing I can do about that. And it always hits at these very, very predictable mileages or intensities or surfaces. And then when they rest for a little bit of time, those symptoms tend to resolve. So this is one where you will get some neuro-type symptoms. And so that's a big distinguishing piece between that and medial tibial stress syndrome. The pain will typically be a little bit more towards the lateral side of the shin. And then what I very commonly see when individuals come to me, typically, again, it's runners, and they're coming to see me for a gait analysis. And when we watch their running under slow motion, we very commonly see that they overstride, and they end up landing with a really large heel strike. And so because they have that large heel strike angle, they then have to eccentrically control that plantar flexion using their dorsiflexor muscles, the ones that are sitting in the anterior compartment. And that ends up pulling more and more blood into that anterior compartment and eventually leads to those symptoms. I also really commonly see that as we watch that individual run over the course of their run, if you're just listening to the noise that they make with every step. So it starts with their normal sound as they run, but as they get deeper and deeper into the run, the intensity of the volume of each of their landings becomes higher and higher. So a lot of times you'll hear a bit of a foot slap where they can no longer control that eccentric motion. And so it'll start to happen more rapidly, and then they'll become even more louder. And you'll really hear on the affected side or both sides a more aggressive foot slap as they land on the ground. And so those are the kind of common things I see with chronic exertional compartment syndrome. And really a lot of times for them, you're not going to find a whole lot of research on this. You're not going to find a whole lot of research on shin splints, period. But chronic exertional compartment syndrome, you're not going to find a lot on either. We do tend to see that a lot of times working on those individuals' running patterns, slowly trying to change those to where we change where they strike the ground. We change maybe the midfoot versus forefoot versus rear foot initial contact that they have, that we can start to help to improve their symptoms. But again, you won't find a whole lot of research around that. So the next one we'll touch on is kind of the one we really need to be on the lookout for and need to do a better job clinically on, and that's looking out for stress fractures. So we commonly are going to think of bones as being this static structure. That a bone is hard, rigid, and it doesn't really change, but we really need to appreciate the fact that bones are constantly adapting to the stresses that we impose on it. And with stress fractures, those occur when the bone is no longer able to keep up with the micro trauma that happens when a runner is continually on their feet. So it's not able to recover from the volume of training that individual is dealing with, and we end up developing stress reactions, stress fractures that can develop to significantly more dangerous conditions that could potentially end a runner's career. So when we suspect a stress fracture, we really need to be aggressive on pulling that individual away from the aggravating activities back down to a level that's no longer making them worse. So if somebody's dealing with medial tibial stress syndrome, or they're dealing with a tendinopathy, we can let them run with a little bit of pain. And we could talk through things like the Silbernagel pain model or other ways to monitor that. But when we're talking about a stress fracture, we probably don't want that individual moving or doing anything that reproduces their symptoms. We need to be significantly more aggressive here. So typically, the presentation that somebody's going to describe with a stress fracture is their pain typically increases gradually in their earlier stages of having that stress fracture or stress reaction, and it'll decrease with rest. But then as things get worse and worse, pain's going to start to interfere with their activities of daily living. When they come into the clinic, you're going to notice hesitation with a lot of different movements. So if you ask them to go single leg stance, something that you think is a fairly low level activity, they're going to be hesitant to go single leg stance. Or you ask them to do a lateral step up or some hopping, something that's far below the stresses put on them by running, they will be hesitant to do that. And you'll also often see kind of this weird phenomenon that you don't see with other things, and that's maybe you have them do a single leg stance and they're okay, and then you have them switch legs and unload the affected extremity, and that unloading will actually create their pain, which you wouldn't expect with a muscle or tendon injury, that as soon as you get off of it, you would feel pain. You would expect pain in those to happen when you're on it. There aren't a lot of good tests for stress fractures. So we all probably learned tuning forks and palpation on the bone in school. Well, the statistics behind those aren't very good. So really when it comes to stress fracture, it's having good communication with that individual. You're also going to ask a lot of different questions when somebody comes in with a possible stress fracture. So for female athletes, you want to talk about menstrual disturbances. For male athletes, you want to talk about different things that might lead to understanding their hormones right now. So for a male, that might be asking about his sex drive recently. Has that changed any? You want to look and ask if they have any history of low bone mineral density, whether that's as that individual athlete or in their family. You want to ask about their general nutrition. Do they get enough calories to support the amount of exercise they're doing there, which you may not always get the most direct or honest answer with that. You definitely want to ask about a history of stress fracture. If somebody's dealt with stress fractures in the past, they're going to be more likely to deal with it now. And then you also want to discuss maybe their sports history as a kid. Are they a runner now, but they, prior to starting running at age 30, they never did any physical activity at all? Well, then that's going to kind of set some light bulbs off in your head on this is somebody that never had the loading through adolescence and pre-puberty that would have led to their bones being as strong and fully developed as possible. So a lot of different things subjectively to think about and ask there that kind of add little bits to the equation there on if somebody might have a stress fracture. Now, if you suspect that, getting imaging on it may be appropriate. And it very often is appropriate, but I think it's important for us to understand that with stress fractures, the research says about 2/3 of them are initially going to be negative on an x-ray. And so it's typically going to be better to get that individual an MRI or a bone scan rather than just an x-ray. And so you probably, when you suspect a stress fracture, want to have a really good team of people around you that you trust to refer that individual to help you out in that management. Finally here, we want to discuss tendinopathy in people dealing with lower leg pain. And we're probably fairly familiar with tendinopathy. It's going to be the one of these that we probably see the most frequently throughout the entire body, so it's going to be easier for us to recognize than other ones. Early on, those individuals typically are going to have pain after exercise. As they progress, that pain becomes a little bit more constant. It might happen during their exercise as well as after, but we're very commonly with tendinopathies going to see that warm-up phenomenon. Whereas that individual starts moving, they get their heart rate up, they start loading that tissue, things start to actually feel a little bit better, their pain levels decrease, and then when they stop, those pain levels go back up. We don't really know why that warm-up phenomenon happens in tendinopathy, but it very, very commonly will. The other things that you're going to see, often reproduction of pain with manual muscle testing, as well as pain as you palpate along the tendon there. So there's 4 conditions. The 2 I didn't cover were nerve entrapment and vascular pathology, just because they're not the ones that you're going to see most commonly. But I hope breaking those down and going deeper than just the umbrella term of shin splints helps you out with your clinical reasoning, because certainly right now, while we're dealing with COVID lockdown stuff where people aren't going to their gyms as much, or just this time of year in general where it's a little nicer outside, people are running a lot more than usual. And so this is something that is probably showing up in your clinic a little bit more than it typically does right now. So I hope that helps. As always, check out ptonice.com for future course listings. Have a great Friday and a great weekend, everybody. Morning.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.